Okay. Good afternoon, everyone. My name is Andrew Bluestein, and I'm the Vice Chairman of Garfunkel Wild. I want to thank my co-presenter, Lisa Winkler, for giving us the opportunity to address the members of the Connecticut Association of Ambulatory Surgery Centers. I hope everyone is staying sane and safe. These are difficult times. And today's webinar is going to deal with the prohibition on elective surgery. Bear with us because Lisa and I are social distancing to the max. We're not in the same location, and our IT director is out of our Stamford office, so we're all in different places. If, as we do this, you want to ask questions, you see the dial box, you could just ask it, and to the extent we have time, we will try to get to them. So this topic, I believe, is crucial really for three reasons. One, as Lisa's going to talk about, there's regulatory risk for ignoring the governor's recommendation. Two, there's potential harm to patients, providers, and your facilities in general. And three, there's some moral issues that I think are being discussed. I'm getting a lot of phone calls from ASCs, from physicians, from hospitals, really struggling with what it means to treat patients during this crisis. We're going to explore these issues and help you operationalize what it means to stop doing elective procedures. Before I turn it over to Lisa, I just want to say what we're not covering, okay? We are not covering HR issues. I know we have half of our firm is dealing with calls on that. There actually is, and I'll give a quick plug, there is a webinar also free on HR issues on Monday from 2:30 to 3:30. If you would like to register for that, you can get on Garfunkel Wild's website, hit events, and you can register. Again, it's free. It also won't cover some of the other issues, telemedicine. There are webinars already that you can get off our YouTube channel on that. And also there's one on force majeure, which means how do I get out of contracts, or how do I hold vendors to contracts that they are no longer willing to follow. Okay, so with that, I am going to turn it over to Lisa to talk about the Connecticut regulatory update. Lisa?
Thanks so much. So Andrew, as Andrew mentioned, is the expectation of the Connecticut administration that surgery centers are no longer performing elective cases and only doing emergent and urgent cases in surgery centers. We kind of wanted to give you the context of what's happening on COVID-19 prep in Connecticut. Surgery Center Association participates in a now daily call with the state of Connecticut and other providers as the state develops its surge plan. And just to give you some context on that, the state is looking to have capacity of 25,000 beds in Connecticut to deal with the expected surge. At this point, we have the following numbers in Connecticut as of late yesterday: 1,012 confirmed cases, 125 of those cases are hospitalized, and 21 deaths at this point. I think we expect those numbers to rise significantly. Certainly, we're adjacent to that epicenter in New York, and a lot of those cases are being seen in the Fairfield County area. 607 confirmed cases in Fairfield County at this point. And then New Haven and Hartford are the next hardest hit. The association reached out to all of the centers on the PPE front because the stories that we were hearing out of Fairfield County and the hospitals there were really frightening. And so many of our centers really stepped up, taking into consideration their urgent and emergent care needs over the next several weeks, but we're able to look at their inventories of PPE and provide needed surgical masks, gloves, gowns, things of that nature. And we were able to coordinate those pickups across the state between surgery centers and hospitals. And I just want to really highlight how important that is, because in the context of conversations with the state Department of Public Health, Office of Health Safety, National Guard, the governor's administration, it was specifically referenced on a call how terrific the surgery centers have been in terms of helping bridge the gap that's currently there. We've seen from the National Guard and from some of the hospitals discussions about PPE deliveries being held up at the port and at the airport, so that's really exacerbating the situation as well. Today, we just sent out a survey to the members looking for information on staffing, ORs, anesthesia machines. 3 anesthesia machines were already provided to one hospital from a surgery center that was closed at this point. And for those surgery centers that don't have relationships directly with hospitals, we're looking to gather information in terms of capacity, because the state is looking at colleges, universities, all of those things to try to get to that 25,000 bed capacity. When you look at, I think we have 6,900 plus staffed beds in hospitals. At this point, 932 ventilators at this point within the hospitals, and already 33% of those ventilators are in use. So we really just wanted to give you some context of what's happening, what the association has been involved in, and why we're sort of sending some of those surveys that we're sending. But everything that you guys are doing on the PPE front and just on a daily basis really helps us as we have those discussions with the state. At the same time, we're also looking at things like liability, working with the hospital association, physician partners, and others to try to convey that message to the administration. And then also on the surgery center tax side, requesting that there be a waiver of those tax payments, at least for the next quarter, if not the next 2 quarters. So we wanted to give you the heads up on that as well. I think that gives you a pretty good understanding of what's happening on the regulatory side. Andrew, I'll throw it back over to you.
Okay, thank you. Now, the state of Connecticut is similar to New York and New Jersey in terms of making this a ban effective. New York made it an outright executive order, but I think it comes down to the same thing. And what all the states are doing is they are relying on guidance that the CDC came out with. I'm going to get to that guidance. There's an interesting chart. I am not a physician, although I play one on TV. And it was eye-opening to me, because to me a procedure was a procedure, and I'm sure there's medical people on there who may disagree with the chart. You can disagree with some of the chart in terms of the examples, but you cannot disagree with the fact that you need to make some rational choices and the vectors and the variables that go into that. Lisa talked about the PPEs, and we're seeing, if anyone looked at the New York Post yesterday, I think it was, you saw the people from Mount Sinai with their garbage bags on. As this goes, and the statistics in Connecticut, to me at least, are scary when you see jumps like 42%. I think there's going to be a lot more pressure. I have had ASCs in every state, New York, New Jersey, and Connecticut, explore things. Well, I'm just going to do it. I have to, pay my kids tuition and whatnot. And we're going to talk about that a little bit more. But I feel, especially, I know there's a lot of administrators on, there's going to be, if you could work in an ASC by yourself without any receptionists, without any nurses, without anyone, I would tell you, well, that's your risk to take to some extent, but there's going to be some whistleblowers, and there's going to be people calling up the governors of every state saying, hey, I'm at ABC ASC and look what they're doing, and you should come in here, and that's all you need is another post headline with your ASC in there. Okay, so some of this stuff that information, that stuff that the CDC put out is obvious. And some of it really, we're going to get into it, are things which I think you're going to have to operationalize because it's not the normal state of things, okay? So this is the opening salvo of the CDC guidance, and you really have to prioritize urgent and emergency visits, and that word prioritize. So if there is some type of inspection or whatever, all the administrators on there, they're going to be looking at you and saying, well, how did you prioritize? What actions did you take? What emails? What policies? So I know that sounds very lawyer-like, but when you call me to defend you, that's what I'm going to ask you, because the charge is going to be that you haven't really done this. And I need something. You got to give me some weapons to fight back when we're in the defensive mode. So it goes on that the following action can preserve staff, PPE, and patient care supplies, okay? And the first one is really the subject of today: delay all elective ambulatory visits. The second one is reschedule. I'm going to bring up this example a couple of times because there was an ASC that didn't call me, but they had, I think, a stress reaction, which these days makes sense. And they went and they just called everyone who was scheduled and just canceled, and that's it. And then they listened to a lecture that I was giving in that state, and it's the same point I'm going to make, which is, okay, you just canceled everyone. When this is done, and we all have to believe that this crisis will sometime end, how are you going to get them back? And I said, you just canceled? Was there any thought this person can go a week and this person can go a month? No, and it was a stress reaction. So now they're going back and trying to redo it. We're going to give you some tools to help you do that, okay? Because it's not cancel. I mean, I have an orthopedic ASC that was told me, they just told ACLs, you know, it's 8 months. I say 8 months. It's 8 weeks from now, then call and see where we're at. But they're not doing that for other types of procedures. So there has to be a lot of thought to go into this. There are things that should straight out be postponed. I know we don't have, I don't know we have any dental ASCs, but CDC is all about dental being postponed and just basically your routine eye care visits. If you want to read more about this, we put the hyperlink in there. I'm just going to hit kind of the high points, which I think is probably enough to get you through the day. Okay, so the question is, when we first started this, what is elective? And so, you know, I learn a lot from my clients, and I had a bunch of surgeons on the phone. I said, what's elective? Just give me an example. Give me a definition, simple definition. And somebody gave a definition. Somebody said, I don't agree. And it became a 20-minute discussion. The only thing that they could agree on is everyone knows what the word elective means. So I said, how could it possibly be? Because you've been disagreeing for 20 minutes. I'm going to try to answer that question as best we can. But again, I'm not a provider, so you're going to have to help do it in your language. But one of the things that I'm stressing is that elective status can change, right? We're going to give you some, like a call-in sheet, a log, which I recommend you use, but whoever is scheduling these things has to go and call the patient. So say, hey, Andrew Bluestein, you have X procedure. We are rescheduling you, but you must say to them, if your symptoms or pain change, you need to call us back. Because if you cancel a routine colonoscopy, which you should right now, and it turns out the person starts bleeding, and they're like, oh, well, but they canceled, I'm worried about a potential malpractice action that they're going to say, well, they told me that they wouldn't do it, so what was I going to do? So don't rely on patients to be as smart as they maybe should be. Okay, and we're going to get more into this. I'm just kind of my open salvo. So malpractice versus penalty versus ethical issues. So let's talk about malpractice. And I kind of just touched on it for a second, okay? I have a call today with a group of surgeons. We're going to be writing up a document for them. And it was an interesting conversation. Their point is, what happens if somebody comes in, gets sick from COVID-19, and then blames us, meaning the ASC, for getting it there? So as we talked about it yesterday with a bunch of different surgeons, I said, I don't think that's your risk, because I don't think you'll ever be able to say how you got COVID-19. Did you get it from the center, or did you get it from the elevator button when you pressed it, or did you get it when you went to the grocery to pick up some Starbucks? So there'll be no way, I think, to really bring a case for getting COVID-19 in the ASC, because you can never find it. But where I think you can run into trouble is patient comes in, and of course nobody wants there to be any complications, but there's a complication, okay? And they go to the hospital and realize that I have the honor of being in all 3 states, and they're at different rates. In Manhattan, there are some hospitals that are just straight up on diversion. They won't take you. And there are also hospitals where you're going to wait for days, okay? So I can see a claim coming, doctor, when you did this procedure, yes, you told me about the risk, but you did not tell me about the heightened risks about what would happen if something went wrong, right? Given COVID-19. And I think that those kinds of issues come into the ethical issues, which I'll talk about in a second. And I think that it would be wise to, and even if you don't have a form, you note that in your progress notes. Okay, spoke to the patient, explained to them that, why I thought they should have the procedure, but explained that the increased risk given COVID-19, and they still wanted to go ahead. Okay, now the penalties. So Connecticut strongly recommends it. That's a little bit like when my mother-in-law says, I strongly recommend you come for Thanksgiving. That's not really a recommendation. And I would just tell you, having been a regulatory lawyer in 3 states now for 30 years, that when you ignore what the administration is telling you to do, they have ways of extracting penalties. In New York, it's a crime, and they could take away your operating certificate. I believe that as things get worse in Connecticut, and if the governor hears about ASCs not kind of following along what they should be doing, I think what's going to end up happening is you'll have sudden inspections, you'll have all the things that they can do besides the bad will and all that. And if anyone's a baseball fan, you see what happened with Noah Syndergaard, who's getting his Tommy John surgery. I'm hearing that ASC is besieged, as well as the doctor who flew there. But so this is not something to be trifled with. In terms of the ethical issues, I'll leave that to people who are more philosophically bent than I. But there is some really interesting conversations that I've been participating in, which is, Dr. A says, well, listen, I've got loans, I built my ASC, and I'm going to bend the curve a little. I'm going to say things are non-elective, kind of in the gray area. And then you have other people saying, well, if you're going to take that risk for an 80-year-old patient who actually might get COVID by coming, right, then you're really dealing with a tremendous ethical issue. And so I leave that all to your conscience. So let's go to what is elective. So I gave you the definition in New Jersey. New Jersey happens to be one of the states that actually defined it. It's defined as any surgery or invasive procedure that can be delayed without undue risk to the current or future health of the patient, as determined by the patient's treating physician. Now, I told you that obviously risks can change, but and I'm sure there's going to be questions where people are asking procedures. Is this elective? Not elective? By the end of this, you should realize that that's not a question you can just say, this is, this isn't. But I have been on phone conversations, for example, with somebody who's a pain management, does invasive pain management. And their belief was that anybody who's in pain would be presented with an undue risk if they didn't have that pain addressed. So I said to the person, again, my not being a doctor, I'm allowed to sound stupid. My wife tells me that that's a common thing by me, but I said, so the 82-year-old who needs their 6-month shot in their knee, if they don't get it for a month, is that really going to put them undue risk? Maybe a little bit more pain, but is that undue risk? So that's the kind of discussions that the physicians need to have. Okay, so this chart is really, I keep studying it. I find it very interesting. It was created by an MD, and I think it really kind of advances the understanding of what is elective and gets you to the point where you hopefully will be in a position to make these choices. So it's broken down into tiers. Okay, there's 1, 2, 3, 4, 5, 6 tiers. Okay, the action is postpone or not postpone. So if you look at tier 1A, it's postpone. If you look at the next slide, the last two are do not postpone. Okay, so what's the difference? So I said before about different variables. So let's look at 1A, okay, which is postpone. Okay, low acuity, healthy patient. Okay, as compared to drop down to 1B, that's a low acuity, unhealthy patient. Okay, not life threatening, and I'm not gonna get into what the word acuity means, but it tends to be ambulatory, low triage, not a lot of resources for nurses. We should know. If you're on this call, I'm assuming you know what that means. The locations, if you'll see, there's ASCs in each category except the last two, locations rather. And then you look at the examples. Now, there is somebody who listened to a very similar lecture and called me up and said, well, what I do is not one of the examples. So if I'm following the CDC guidelines, remember, that's what the governor of Connecticut wants you to do, then I have more discretion. And I said, doctor, what does the word example mean to you? It doesn't say definitive list. This is one doctor's view adopted by the CDC to try to shape the concepts. So if it's not here, do not make that mistake, okay? But let's look at, again, we're in tier 1A. So that's a cataract. I know we have some eye surgery. That's a postpone. Now, again, I don't know that the person who did this is a medical, is an eye surgeon, but are there cataracts that maybe are not simple cataracts and really need to be addressed? I don't know, but again, that's where you are. Colonoscopy, okay? EGD and carpal tunnel release. Now, I got a call from an orthopedic surgeon who said there are sometimes you could have, tennis elbow, okay, fine, you can postpone that. But he said sometimes the sensation in your fingers or the lack of sensation can become so intense that if I don't relieve that, you could lose feeling forever. So again, it's about documenting in your medical record the reasons why you're doing this. And that's why this becomes hard. Nobody ever had to do this before, I believe, unless you were around, during the Spanish flu of, I think it was 1918. So you're going to have to over describe this, okay? I'm going to give you a form in a second, which should help. Okay, so I spent a lot of time in 1A. Now I'm going to go faster. 1B, you see, it's the same thing. They put endoscopies, but if you look at this, and this is an interesting vector, healthy patient and unhealthy patient, it's still a postpone. Low acuity is really the more intense category, I think. But it's very interesting that when you're dealing with unhealthy patients, I think the pressure on postponing that case becomes higher. Because remember, one of the things, and Lisa alluded to this, that we're trying to do is to prevent people from showing up to hospitals that are already having surge problems, okay? Now, tier 2A is where it becomes real interesting because you're considering postponing. So I have immediate acuity, I've gone up in acuity, I've got a healthy patient, okay? Stop right there and compare that with 2B. I also have intermediate acuity, but I have an unhealthy patient. So 2B is a postpone, 2A is we have to consider it, okay? And again, you can't, this is a chart that it's not holy writ. So somebody called me up and says, oh, 2A says requires in-hospital stay, so I don't have to have an in-hospital stay, so it doesn't apply to me. No, because if you look at location, it's ASC, you know, they were just doing it. And then you look, I know we have a lot of orthopedic ASCs on the phone, so take a look, non-urgent spine and ortho, including hip and knee replacements, okay? And then we talked about 2B. You know, it's interesting. There's no examples in 2B, and I don't know what Dr. Shamir was trying to do, but I think what happens here is we're postponing. So my view of this is all of those things that you have examples in 2A, because you have an unhealthy patient, are really the examples. You could transfer them to the box that's empty, and now you postpone it because of the health of the patient, which I think is important. Okay. The next two is do not postpone, and that's really hospital, but that's high acuity, and you can look at the examples there, and it's obvious that there are things that you need to, you know, to do, and that makes this very difficult. Okay, so now we come into how do we operationalize this, because I think we now know, or a little bit more educated on the lines that we need to do. So first of all, you need to create a policy, whether it's your board or your medical director, and it needs to be distributed. Again, if when the smoke clears, you call me to defend it, I'm going to need that. But more than that, it's not just about me. It's about letting your staff know. There are people, I think correctly so, who are feeling extremely strong about the need for everyone in this country to come together to try to solve this. So once they see that, I think it's going to have a calming influence and a goodwill influence. Okay, but who's going to make this decision, right? I was on a call with an ASC the other day, and they're like, well, the ASC will do it. And I'm like, the ASC? What is the ASC? It's four walls, right? It can't make those decisions. Those decisions have to be made by the physician, okay? So we came up with this extremely simple form. I've gotten a lot of calls after I do these lectures saying, well, where in the law does it say you have to use this form? It doesn't. This is one harried healthcare lawyer's attempt to try to help you. You could put this in your medical record without this form. I'm saying you could just write what's there. You could expand on it. You could do whatever you want. However, if suddenly you have an inspection and you did 50 cases, you better have 50 supports for why they're not elective, okay? So you would do this. Let's say I was the patient. Andrew Bluestein, my date of birth, scheduled procedure. I, the undersigned, as a doctor, I'm aware that COVID-19 and executive order has been issued requiring hospital and surgery centers to cancel or postpone. I've evaluated the patient and have determined in my professional judgment. So you don't have to be, somebody else could disagree with you, but it has to be a reasonable judgment that the risks to the patient that would result from postponing or canceling this procedure is such that the proposed procedure is not elective. So again, every procedure that you're doing should have something like this. I've had people say, I want to write more. You can write whatever you want. The more you write, in some ways, the better it is, because you will be supporting, you know, your decision. So Andrew Bluestein, you know, if you wanted to write here, originally it was just his yearly colonoscopy, but he called that he was having cramping and bleeding, and now it became a concern is potential cancer or internal issues, whatever it is. That's supportive. Okay, going on. So also, you're going to have to require the treating physicians, and the ASC can help here, to keep a list of cancellations for callbacks, okay? This is what I had mentioned before, and I'm going to show you this list here. I'll just give you a quick peek. There's the callback log. I'm going to come back to it in a second, okay? You, again, when you send your instructions to your staff, make sure you tell them that each patient should be told to call back if the condition worsens or they have significant pain. I am really worried about that. It's not normal. A doctor gets sick one day and cancels his office hours or his procedures. Okay, you know how to deal with that. But you're canceling, and God knows how long this will go on. Hopefully it's short. But you're going to have to not just react like the upset ASC that I told you about. And that relates to having a callback date. Put the onus on the patient, and I'll tell you in a second. And then you have to implement precautions to protect patients, and we're going to talk some about those precautions. Okay, so let's take a look at this callback. So patient Smith is the patient's name, ACL. He was scheduled for April 2nd. Callback date. What I mean by that, again, is that's when the patient should call you back, okay? Now, outcome of callback, we schedule for July 1st. So what this means is, and the reason why I think this, again, we're trying to do simplicity in this age of insanity, but what we're doing here is, at the end of it, you have this all filled out. So every callback date, so, if you have this on like a computer, you'd search for today's date, or maybe you let it go a couple days and you call the patient back. Hey, patient Smith, you were supposed to call us back. How are you feeling? Blah, blah, blah. Oh, everything was going on. I forgot. Okay, let's reschedule. Now, if you're listening, by the way, don't forget to add questions if you want. But if you're listening, you might say, well, how do I know? The patient will say, how do I know when this is going to be over? And you don't. But if you keep working the callback log, when it's over, you'll at least have a lot of people scheduled, so it's not a complete chaos where everybody wants to come in that day. Okay, let's talk about precautions. These precautions come borrowed from different sources. They come, the National ASC Association had some things, CDC had some things. I'm going to fly through this, but they're kind of obvious. But again, I worry about the inability to operationalize this, okay? Pre-screen all patients for symptoms or high-risk exposure. I'm assuming that you're doing that, but my guess is many of you are not doing it uniformly. Again, I'm all about scripts. You got to ask the questions, and there's going to be more things here. And, I haven't developed a questionnaire, but it's not hard, okay? Tell patients who say, no, listen, I'm fine. Give us a call, 2 days before so that you can check in with us about how you're doing. When the patient comes in, I have ASCs that are not taking temperatures, and I have ones that are taking temperatures, okay? Again, you're not just protecting the patient, you're protecting yourself and your staff, okay? Go through it again. We all are reading the same articles. I was fine, and 48 hours later, I was on a respirator. 72 hours, I was dead. So this virus comes on really quickly. But ask them, don't you say, how you feeling? Which is what normally would have done, maybe. Fever, sore throat, cough, other respiratories. And then ask them about other symptoms that family members may have. Have they been in contact? I will tell you, in our own office, there's somebody who was feeling fine when they came in, but their spouse was not. They infected at least 4 or 5 people in our office, okay? I'm not happy with that person, but you have to be smarter than the patients, okay? Again, we talked about checking temperature. Prohibit individuals from entering if they are experiencing elevated temperature or symptoms of COVID-19. Now, I had an ASC where the staff literally walked out of the ASC. Why? Somebody came in, they had temperature. I don't even know how they allowed. No, I'm sorry, it wasn't temperature. They were having a hacking cough. The physician felt that, you know, their program, treat, how could they turn them away, blah, blah, blah. And the staff, ultimately, some of them did get sick, but they were so disgusted by the fact that this patient was treated. Now, you might say in your questions, well, what about if the patient is, you know, so severe, blah, blah, blah. Okay, we could talk about that, okay? Limit visitors to those who have somebody coming with them. We all know you have to have an escort and all those other things, but I've seen some really creative things happening with escorts. You don't need an escort when they come in. You can say, okay, we're asking you to please wait in your car and we will call you when the escort's ready. Keep the escort out of there, okay? Also provide a lot of, for your staff too, I'm sure you're doing this, tissues, sanitizers, all these things, okay? The next one was interesting. I would never have thought of that. You have that, you know, National Geographic that hasn't been changed for 4 years. Think about how many people pick that up, throw them out, okay? That little candy dish, get rid of it, okay? The common pens. So you really have to think this through. And then, to the extent possible, everyone has to wear the right PPEs and optimize the supplies that you have. And Lisa talked about, you know, the donations and things like that. Okay, so moving on. Again, we have visitors and vendors. We have in our own firm, vendors are leaving it on a different floor when they come in, and we're going ahead, we're wiping down boxes and things like that. We're not even letting them get anywhere near other people. We're also letting FedExes and things sit for 24 hours. That seems to be the new recommendation. Okay, follow-up for patients 7 to 14 days afterwards. If they sound like they're getting COVID-19, it may have nothing to do with you, but you're all in the healthcare community. What's your script for what you're going to tell them? Where are you going to refer them? Okay, in terms of staff, again, send emails. Don't come to work with symptoms. As I said, I have a healthcare lawyer in my firm who didn't follow our own precautions. Okay. I didn't advance. Okay. So we're coming to the end, but I really want to talk something Lisa mentioned is very important. Hospitals and ASCs. There are some really good conversations going on. There's not enough of them, in my humble view. Okay? And there may be things I don't know about. But like, for example, one ASC that I'm familiar with, which is, actually they're not the only one who's doing this, but they are an endoscopy center. And they're going to be shutting down. But they came up with a great idea. And I'll share it because I think it's something you might want to consider. They said, listen, we're not set up to do, you know, a lot of surgeries. We're a single purpose ASC. But they could do infusion treatments. So having conversations, I hooked them up with a hospital I represent. The hospital's like, well, that's a great idea because we've got some immunocompromised patients coming to the hospital, which is swimming in COVID-19. And you've got all the chairs there, the recovery chairs. We can move the whole infusion department into the ASC. The ASC nurses can give the infusion treatments. And now the area in the hospital, which has been cleared of vulnerable patients, can now be repurposed for beds or whatever. That's the kind of example of excellent coordination that needs to occur. And again, you got to communicate to staff. There are huge HR concerns. You know, listen to our thing on Monday and call us. You know, with the stimulus bill, we're all breaking it down. What does it mean? We're going to have a separate webinar on that. But at the end of the day, people are getting laid off right and left. There's furloughs, there's salary reductions. How do you do that? And guard your supplies, okay? Special consideration, pain management, I talked about. I'm worried that that's an area that is subject to abuse in terms of saying everything is elective, is not elective. Continue monitoring the evolution of COVID-19. I think this is crucial, especially for Connecticut, where you're X days away from New York City. I think as that scenario changes, bringing in the 80-year-old who really needs the surgery, but as it gets more and more risky, maybe that changes that CDC categories that I went through, okay? And consider use of alternative venues. Lisa talked about that. Where else can you do things? And talk to the hospital. Maybe they want to shift cases to you, which hospitals don't love to do, but I'm hearing them say, yeah, we're done. I mean, we can't do it here anymore, because they're having the same ethical conversations. Okay. So now we can talk about questions. You can put them in there. Lisa, I'm going to ask you a question, which we've had from ASCs. What happens if I give away all of my PPEs, and then I either have cases that start coming back, or I have cases that I'm doing, or the hospital wants me to do things. Now I don't have anything to protect my staff. How would you respond to that?
Right. So when we sent out the survey to our members, we asked people to be mindful of what emergent and urgent cases they're going to need to be doing over the next 8 weeks. We put that in there as a time frame because we wanted, to your point, we don't want people giving up completely their critical resources. And also as things like surge capacity and kind of thinking outside of the box, as you discussed, that infusion concept. We have a lot of centers talking about doing different things to accommodate capacity from the hospitals. So I think certainly when we ask centers to be mindful of that when they were thinking about what they could provide to the hospital. So certainly on that front, I do want to just mention that as we were on the call, one of the centers just emailed me and mentioned that three of their anesthesia machines, which can then be used as vents, were getting picked up to go to the hospital locally today. And then one of their centers, 3 of theirs are going. So at that point, it makes it, I think 9 ventilators / anesthesia machines have gone to hospitals from surgery centers down in the Fairfield County area. So just know that those efforts do not go unnoticed, and it's really important for us to be part of the solution as we work through this. That looks like different things for different centers, and so to your point, we're going to be accommodating some of those urgent and emergent center procedures that need to be done, certainly, and those will be ongoing. But for those centers that are shut down, there are opportunities to be engaged in different ways.
Great. Okay, somebody asked the question, if the ASC does cases, is there a recommendation for all staff to have an N95 mask? That is what the CDC is suggesting. I understand that there are, in some places, an inability to get them. What I have seen also coming out of the CDC is, it's really supposed to be for single use. They're allowing some multiple use. They're talking about ways to deal with that. But yeah, I think an N95 mask is important. Another question.
I just want to mention.
Oh, go ahead.
So sorry. I was just saying I want to mention one other thing. It was sort of raised. As you think about from your center sharing equipment like anesthesia machines and vents, some facilities are developing agreements with the hospitals, so it's very clear and documented, which I'm sure, Andrew, you love to hear that, what is being shared, serial numbers, things like that, because again, to your point, you want to make sure that you get back your equipment. And, that you kind of have your T's crossed and your I's dotted so that when we're back up and running again, you have what you need. And I think that there are some folks who'd be willing to share, you know, the draft agreements that they've put together if that's something that centers need.
Yeah, 100%. What I also would tell people, and this goes back from my corporate days, I love stickers because one ventilator looks like the next ventilator. So you might get back a ventilator. Is it the exact one you gave? Did you record this, the serial number? Okay. But I love stickers. Put a big fat sticker, property of ABC, ASC, right on it so that it's always yours. Even if you don't have an agreement, which I agree you should have,
Right.
that is there. Now, what I know we're a minute over, so I just want to close with one point. People are asking me, can the government come in and take over my ASC? And the answer is, you know, we're at war, right? And in war times, the government has tremendous executive power. And could that happen? Yes. That's why I think it's in your own best interest to start coordinating with hospitals. Because if you already have an arrangement where, you know, on Monday, Wednesday, and Fridays, they can, you know, recover people here who have had cardiac issues or whatever, then you're already part of the solution. The people I worry about are the people who are kind of floating out there without any kind of protections. So, all right. So with that,
hey,
we
Andrew,
covered a lot. Yep, sure. Yep.
I'm sorry, there was one more question that speaks to office-based surgery centers. And so in Connecticut, you know, the trigger is levels of anesthesia. And so it's the same regulatory oversight based on, you know, office-based surgery centers as well. So those entities are really captured under the ASC umbrella. So I know that there were a couple of questions there relative to office-based surgery centers, but those are contemplated as ASCs as well in Connecticut.
Yeah, I didn't see the question flash. I will tell you that the reason why I think some people are going around